Hi, everybody. This lecture is on the development of the swallow in the normal child. And the age period we're going to be looking at is actually in the fetus. The fetus does begin to swallow very, very early in the first trimester. What do they swallow? Amniotic fluid. That's all that's on the menu. And we're going to look at infants, which technically goes up to 1 year of age, and then up to 3. And after 3, there is not much difference, except in size, of course, but there's not much difference in the anatomy and physiology of the swallow. So that's the time period we're going to be looking at. Let me share my screen. You have the slides. And I will enlarge that. And there we go, normal deglutition in infants and children. Now, let's look at infancy versus a little bit older, that is up to about 3. So infants, again, are defined as the age group up to 12 months of age. And I'm going to go back and forth between these two columns just to compare similarities here, similarities and differences. So first of all, in the infant, the tongue fills the mouth. In the older child, as in an adult, the mouth is larger and the tongue rests on the floor of the mouth. And as you sit there right now, you can probably detect that in yourself, that you're easily able to create a significant space. In fact, if you're just resting, your tongue will be in the floor of your mouth and there will be a space above it. Going to teeth, the infant, of course, is edentulous. And then in older children, dentition is present and it's developing. We'll look a little more at the age period of that, but that would be the basic there. Then, and the third bulleted point has to do with the sucking pads versus the buccinator. In the infant, they don't have much control of the facial muscles really, but they need to keep the buccal cavities empty, just as we do, and we've described that in the normal swallow for the adults. They don't do that through muscular action, but through these little fatty pads called the sucking pads. Those sort of go away then in that first year, and the function is replaced by the buccinator muscles, which you're familiar with from your anatomy and physiology course. Of course, the muscles are there before, but they begin to take up this function of keeping that buccal cavity closed and off limits to material that is taken into the mouth. But they do it more through a combination of their tone and their mass. And then finally, there is a change in the mandible. There's a small mandible in the infant. It does grow. It actually elongates. So if you look at an infant, their chin will be a little more retracted. And as the infant develops and becomes in this category, what we're calling older children from 1 to 3, the mandible is larger. All right, going on. Now, I feel like I skipped a slide, and I did. So let's go back there. I'm going to look at the development of the suck and the swallow. Now, this is actually before birth. So the pharyngeal swallow is first observed in a fetus at 10 to 12 weeks after gestation. The way that has been determined is, of course, through the sonography, the ultrasound, and they can actually see the child producing a pharyngeal swallow with the various closure of the larynx and elevation of the larynx and so forth and so on that you know about. And what are they swallowing? Again, amniotic fluid. Then suckling, and we're going to look at suckling versus sucking in the next slide. But the first way of getting material into the mouth is a process called suckling as opposed to sucking. And it begins in the 18th to the 24th week. That would be around the second trimester. And of course, this can be observed in an ultrasound too. And then what are they suckling on? Well, typically their fingers. Their fingers is what they're suckling on. And the movements that we're going to describe in that next slide can actually be observed in an ultrasound in that fetus in that time period and afterwards, of course, but that's when it develops. They have actually an infant, or I should say a fetus, would have functional suckling and swallowing. Possible from the 32nd to the 34th week, someplace in that window, it'll actually become functional. In other words, before that, if the infant were born prematurely and saved, which is very possible, that happens frequently actually, those infants fill the NICU. But an infant born before the 32nd week post-gestation doesn't have a functionally suckling and a functional suckling and swallowing response. They have suckling and swallowing, but not good enough to survive with. So by the 34th week, most infants, if they're born in that time period, can actually survive with oral feedings. And remember that 39 weeks is full term. Now, one of the things that happens in terms of the development that allows the child to survive at the 34th week on oral feedings is they develop a sufficient ability to, quote unquote, self-regulate. A self-regulation is being able to modulate your own input and effort level and consciousness level to maintain an effort on some task, whatever that might be. And I'm sorry I lost that, so I'll bring it back. And I don't know what happened here, but I must have pressed something. Okay, yeah. I pressed something, sorry about that. So in order to self-regulate, well, let's take an example. You all are self-regulating right now by paying attention. You know, for however long this is, you have tremendous, as a young adult, you have tremendous ability to self-regulate. But when you go to an infant, particularly in this early stage of prematurity, one thing that keeps them from being able to self-regulate it is that they're highly distractible. So they might start suckling and swallowing, but they're highly distracted by any environmental stimuli. In other words, they can't stay on task with that. They may not be able to regulate even their consciousness level and stay awake. So they'll drop off to sleep too soon. So they can't keep going. Or they'll become so hyper alert due to distraction that they can't even begin to latch onto a nipple. So they need to develop the ability to self-regulate for a period of at least several minutes in order to be able to have sufficient functionality in their suckling and swallowing to survive on oral feedings alone. Now, the SLP and the nursing staff will help the infant to self-regulate by controlling the environment, create a nice quiet environment. They'll even do something like change the size of the aperture in a nipple so that it produces more liquid on every suckle, so that the child doesn't have to persist quite as long. So that's part of what goes on with an SLP and nursing in a neonatal intensive care unit, is to regulate the environment and other variables involved in the feeding process to allow the child to be on oral feeds. Before that, they may be on a combination of oral feeds to help them develop, but to be supplemented by tube feeding. And when we have our lecture by the person from CHOC, the SLP, Melissa from CHOC, she will, of course, elaborate on that quite a bit. Okay, now. Okay, now we're going to look at suckling versus sucking. I told you that was the next slide, but I guess it was 2 down. Suckling is the earliest intake pattern for liquids, as you already know. It's possible in the 2nd and the 3rd trimester of fetal development. And what it consists of is a back and forth movement of the tongue tip up against the alveolar ridge and posterior to it. So what is happening is that the nipple's in there, and the tongue is under it, the roof of the mouth is above it, and the child is going to milk the milk out, just like you would if you at all familiar with milking a cow or a goat. You latch onto the top of the nipple and squeeze, and then a little further down, and so you're expressing the milk through pressure from top to bottom. Or I guess you could say from the base of the nipple to the tip of the nipple. And that is the way a child suckles, with the pressure of the tongue tip against the nipple and the roof, sandwiched in between the roof of the mouth and the tongue. So they're drawing the liquid out, or through rhythmic licking action combined with opening and closing of the jaw to help that movement a little bit. The lips are loosely approximated. In other words, they're not getting the milk out through a suction process, and therefore they do not need to be, the lips don't need to be sealed against the nipple. Now, sucking is going to be the second pattern, and that will start to develop around the 6th month of age. Of course, there's individual difference. And that will require an up and down movement of the tongue with a little less movement of the jaw. And it does require firmer approximation of the lips around the nipple so as to be able to create negative intraoral pressure, which then sucks. It doesn't squeeze, it sucks the liquid out of the nipple instead of using pressure on the nipple between the palate and the tongue tip. So how do you know Boyle's law? Remember Boyle's law from speech science, I guess it would be. You take the space in the mouth and with a good seal around the lips, drop the jaw down and the tongue down, and you're taking a volume of space inside the mouth, the oral cavity, and enlarging it, therefore dropping the pressure in that environment and drawing the liquid out. So there is the difference. Of course, sucking is more efficient, but the child doesn't have all the capabilities at birth to produce a sucking response. For some reason, my computer's being a little bit temperamental here. Okay, here's my next slide. Hopefully, I haven't skipped anything. Now what we're going to do in the next few slides is to go through a series of ages to see different things that emerge, different skills and potentials to emerge. So in the neonate, which is right after birth through the first month of life on Earth, there is a suckle response on a nipple. There is nasal respiration. There's a rooting reflex. And the rooting reflex, I'm going to define that as well as several other reflexes that are present in the infant in the next slide. I think it's the next slide. But let me define it right here. It's a reflex that helps the infant find the nipple without benefit of visual stimuli. In other words, they don't look around for it and find it. It's a reflex that is elicited by stimulation around this area. And then the child will turn toward the nipple and latch on. So you can artificially elicit the rooting reflex as a test to see if the child has it, simply by stroking lightly on the chin in the direction of the lips. And the child should turn and latch onto that. Okay, now, flexion posture is optimal for feeding and depends on the caregiver. What's a flexion posture? Well, neck a little bit, head a little down like this, back slightly rounded, things sort of folded in. And if you just watch the way a mother or other caregiver kind of holds an infant in the arm here, they are in a flex position, the whole body. And that's optimal for feeding. However, an infant is too hypotonic to maintain a flexion posture independently. They just can't do it. They'll just be like kind of a rag doll. So that needs to be provided not artificially, but from the outside. And they will be hypotonic up to about 30 weeks of gestational age. And then they begin to be able to produce some degree of flexion by themselves. And of course that improves over some time, and not very long either, by the way. But certainly for the neonate, you need to get them into that flex posture for feeding. They do have incomplete lip closure, as we already talked about. And at times they're unable to release the nipple. that presence of that reflex, just takes over, and they sometimes can't quite release very easily. They have to be helped a little bit. Okay, now the normal response in infants at 2 months is that they have greater range of mandibular movement. The suckling pattern continues, but you can see in terms of the movement here, it's they're developing what they're going to need in order to be able to suck. The mouth opens in anticipation of food based on visual already at 2 months. So they're already starting to respond to visual cues, meaning they're not going to need that rooting reflex much longer. Lip closure is improved, and active lip movement makes sucking possible. So they're not sucking yet, but they're getting the movement capabilities in the lips and other parts of the mouth as well. At 3 months, nipple feeding continues. Neck flexion continues to widen the pharyngeal airway by flattening the pharynx and assisting in keeping the tongue from falling back. And the child has better ability to independently achieve a flexion posture. They don't need quite as much assistance from the caregiver. And they do continue taking liquids. Now, at 4 months, there begins to be more dissociation of movement between the lips and the tongue. So that's going to give greater capabilities for oral control of a bolus. Lip pursing becomes better. They start blowing bubbles with saliva, and of course they're experimenting with what they can do with that mouth. They have increased sound imitation, and they have better voluntary control of the mouth. At 5 months, they can hold a nipple in the center of the mouth with balance and stability. They don't need as much help from the caregiver. The tongue has a small range of movement, of up and down movement, that's characteristic of the suckling, but it is getting better. And they do have tongue reversal after a spoon is removed sometimes not always, resulting in involuntary ejection of the food at times. They can begin to take purees in addition to the liquids, and they often gag on new textures. And I'm going to go back and search because I thought we had a slide on the reflexes, but I've not run into it yet. So I'm just going to go backwards, and I'll come back to the next slide, which would be 6 months, since we've done 5. Oh, here we are with the reflexes. So we already went over this rooting reflex. We went through the suckling reflex. The tongue reflex is the front to back licking motion of the tongue generated by a finger or nipple placed in the mouth. So that tongue reflex is a part of the suckling reflex. And you can actually elicit it and test it in a preemie, for example, to see if they have it, because they're going to need it in order to suckle, simply by putting some finger pressure on the blade of the tongue. The swallowing reflex, you know what that is, and you know that it develops very early. The bite reflex, it consists of the baby opening and closing the jaw to bite up and down when you put pressure on the gums. So that is a normal reflex at that age. Of course, it will be lost later. And then the gag reflex is present and protects the baby's airway from swallowing things that are too large. And as the child ages, or the infant, I should even say, it begins very early, the point in the mouth that where the gag reflex will be initiated moves from front to back. In other words, way out here toward the front of the mouth is enough to elicit a gag reflex in an infant. But as we age, it takes stimulation further and further back. So you know that if you are testing an older child or an adult for the gag reflex, you do it actually by touching the very back wall of the throat, and that'll produce a gag reflex. Touching the tip of the tongue will not in an adult. But that gag reflex, the points of trigger move backwards in the aging process. Now back to, there's 5, and we did that one. Now 6, okay, sorry about that. Normal responses in the infant at the 6th month would be tongue and jaw have larger range of up and down movement of the sucking pattern. Both suckling and sucking may occur, but they begin to suck more and suckle less, and to become more efficient and effective in the use of the suck response. And as I had mentioned earlier, it is a more efficient way to get material into the mouth, sucking is. They may tend to push semi-solid foods out of the mouth with the tongue. Teething usually begins, and it's variable from one child to the next, but generally speaking, 4th to the 7th month is when they first begin to teeth. And of course, that goes on for several years. And they do have increased active oral play and exploration. The rooting and bite reflex are gone. Okay, so as they move into sucking, they don't have the bite reflex, or they don't need it anyway. And the rooting will disappear as they're using visual now to receive their required cues. And the gag reflex continues to move posteriorly and to diminish, as I mentioned. And they can have longer periods of lip closure. In the 7th to the 9th month, the gag reflex subsides further, meaning it's moving back and becoming less sensitive. They have still more use of the mouth for exploration. So we're talking about kind of a continuum that's ongoing. They have greater coordination of lip, tongue, and jaw movements in all positions. Drooling subsides except when they're teething. They start to have cup drinking with the lower lip as a stabilizer by the 9th month. And they can close their mouth around the cup edge. And a tongue and upper lip are coordinated to clean off a spoon. In the 10th to 12th month, they start to be able to finger feed. They can wean from a nipple as cup drinking increases. There's great cultural and individual difference in that, with some children continuing to feed from a nipple or breast for several years, actually. And there's a descriptive literature on that if you're interested in that area. They are easily able to close their lips on a spoon to remove the food. They can have a controlled, sustained bite on a cracker. So we're starting to get the skills for solid foods. And they chew with up and down movement of the mandible combined with diagonal rotary movements of the mandible, which you recognize as being the normal pattern for chewing in an adult. In the 13th to the 18th month, they can take all textures and straw drinking is possible. And in the 19th to 24th month, they can swallow with lip closure. Chewing movements are precise. Self-feeding predominates. Of course, there's individual difference in all of these, but self-feeding predominates. And they can take chewable foods in greater quantities and with greater ease. And then in this year, the 24th to 36th month, they have total self-feeding. They can use their forks, chopsticks, whatever it is that they're given with independence, and they take solids of all types. So that is the end of that. And of course, write down your questions and refer to the slide if you can, so we can go right to it when we start our discussion of this material, and then we'll have some problem solving on it as well. And I will close that out.